In general, at the beginning, if the driving alteration was KRAS, it's unlikely that the tumor cells would have EGFR or ALK. On the other hand, sometimes in the presence of an EGFR activating mutation and in the presence of an EGFR drug, some of the cells will become resistant by developing KRAS mutations. Similarly, for ALK fusions, some cells, a minority, but some may become resistant by developing KRAS mutations. So if you have a patient with an EGFR mutation who becomes resistant by the KRAS mutation, it will make sense in the future to consider treating that patient with a KRAS G12C specific drug. So all these molecular alterations, one mechanism of resistance is to develop mutations that will prevent binding of the drug. But another way to become resistant is to develop activation of another pathway, which may be KRAS in some instances for other activating pathways such as EGFR, ALK, ROS1, and so on.
In general, we test for KRAS mutations in patients with non-small cell lung cancer. And we've done this broadly for all cases, recognizing that we identified this gene a long time ago and well before the discovery of EGFR, MET, and the other oncogenes such as ALK, ROS1, and RET fusions. We've done this testing in the earlier phases also in part because we know that these hotspot mutations tend to be mutually exclusive with these other drivers of oncogenesis, meaning when you find a KRAS mutation, there is a low likelihood that you might find another oncogenic driver. The one exception that we've learned about more recently is that KRAS mutations can sometimes co-occur with other drivers like MET exon 14 alterations, and the RAS mutation can be found either in a de novo or acquired fashion. But in general, for the other drivers, these tend not to coexist with those other driver states.
In the old days, one strategy was to test KRAS first because it's the most common, and then only look for others if KRAS was negative. That's, in my opinion, not a particularly good strategy. So nowadays, basically, every NGS panel will have KRAS mutations as part of the panel because it's the most common alteration. And so essentially every panel has KRAS mutations as part of the panel nowadays. If you do these tests sequentially, it's going to take a very long time to find out how you're going to treat a patient. So again, the old strategy was to do, for some people, to do KRAS first, and then if it was positive, that's the end, and if it was negative, to look for other alterations. Right now, the common alterations are in panels. Some panels are larger than others. Foundation 1, for example, has 400 genes that they're looking for mutations. In our particular University of Colorado panel, we only have 40 genes because those are genes that are most common and for which there's a potential treatment. So in the foundation panel, there are many genes that might be mutated for which there's nothing you can do clinically. And even now, for many of the KRAS mutations that you find, there's no sense to look for another if you have it, but there's no specific treatment. Right now, the only specific treatments are basically based on G12C, for which there's some covalent drugs, binding drugs that will prevent KRAS activation.
My practice, particularly for stage 4 metastatic lung adenocarcinoma, is to do broad genomic profiling up front, consistent with NCCN guidelines. And the reason I do that is, things have evolved from what we used to call the big three, EGFR, ALK, and ROS1, where you can match to EGFR, ALK, and ROS1 TKIs, respectively. We have so many other agents now. We have, where MET exon 14 capmatinib is approved, BRAF V600E, there's dabrafenib, trametinib, RET fusion, there's selpercatinib. So with all these additional mutations, I approach it from the basis of getting broad genomic profiling to try to find targets, give us the high percentage chance as possible to find targets to match to effective drugs. And beyond that, at UC Davis, we have clinical trials for HER2 and other molecular subtypes. So it also broadens the scope to bring clinical trials to our patients. So I approach broad genomic profiling, particularly for lung adenocarcinoma, for squamous non-small cell lung cancer, particularly in patients who have a scant tissue specimen or have a never or light smoking history. I also pursue upfront genomic testing. At some point in squamous histology, I do get genomic testing. If the patient has a heavy smoking history, often at UC Davis, we get it as part of our lung map master protocol, which is an NCI-sponsored clinical trial that looks at next generation sequencing and includes squamous cell carcinoma to try to match the targeted therapies, where the study helps support those getting that sequencing result by Foundation Medicine.